The clinical term for chronic sleeplessness derives from a direct translation of Latin roots, in, meaning without, and somnia, meaning sleep. While many experience an occasional restless night, clinical insomnia involves a distinct, sustained pattern of physiological disruption. The disorder is categorized by persistent difficulty in initiating sleep, maintaining sleep throughout the night, or returning to sleep after waking prematurely. This ongoing deficit degrades a person's daytime functioning, causing fatigue and eroding focus. This severe disruption is driven by a measurable physiological state, neurobiological hyperarousal. To understand how this pathology takes hold, we must first map the baseline circuitry that governs the brain's sleep-wake cycle. Insomnia is an active, hypervigilant neurological state that the brain is unable to exit. Transitioning from long hours of wakefulness into rest requires a precise chemical equilibrium within the central nervous system. The process begins with the sleep-promoting centers in the hypothalamus. These regions release a specific cocktail of inhibitory neurotransmitters, including GABA, serotonin, adenosine, melatonin, and prostaglandin D2. On the opposite side are the wake-promoting, or arousal centers, including the reticular activating system. These arousal regions flood the brain with stimulating substances, catecholamines, orexin, and histamine. This interaction operates as a mutually inhibitory push-pull system. As you fall asleep, sleep centers send inhibitory signals, systematically quieting brain activity. After rest, the process reverses. Arousal centers reactivate, suppressing sleep centers to promote daytime alertness. Falling asleep requires the active, aggressive suppression of the arousal network by the sleep network. The daily timing and intensity of this push-pull mechanism are governed by two distinct macroscopic processes. This graph tracks the wake-dependent sleep drive. As we stay awake, adenosine accumulates outside neurons. Crossing a threshold triggers sleep-promoting centers to fire, suppressing arousal. Alongside it, this sine wave maps the circadian rhythm, our internal biological clock. This clock is structurally centralized in the suprachiasmatic nucleus, or SCN, located within the hypothalamus. The SCN coordinates the timing of sleep by processing external variables like light, alongside daily social routines and factors, and biological inputs like melatonin levels. Healthy rest occurs when a sufficient chemical debt of adenosine aligns with the biological timing of the SCN rhythm. In insomnia, this equilibrium collapses. Wake-promoting centers operate in overdrive, while sleep centers fail to generate inhibitory output. This leaves the nervous system trapped in hyperarousal. The switch flickers, unable to lock into the sleep position. This hyperarousal manifests cognitively through racing thoughts and emotionally as persistent anxiety. Systemically, the body responds with distress, including an elevated heart rate, severe muscle tension and stiffness, and excessive night sweats. Over time, this persistent waking state desynchronizes the overarching circadian rhythm, fracturing the body's natural 24-hour cycle. The insomniac brain is functionally locked in a high-alert state, unable to execute the biological command to stand down. Based on exactly when this sleep-wake switch fails during the night, clinicians categorize insomnia into three distinct temporal profiles. Onset insomnia describes an inability to initiate sleep at the start of the night. Maintenance insomnia occurs when a patient wakes during the middle of the night and struggles to reinitiate the sleep cycle. Finally, late insomnia involves premature early morning waking, followed by an inability to return to sleep. A variety of internal and external variables can trigger these system failures. Common catalysts include stressors such as major life events, the loss of a loved one, or rigorous academic and professional demands. Psychiatric conditions like depression and post-traumatic stress disorder carry a heavy correlation, while genetic family history and biological sex also demonstrate distinct prevalence rates. Certain pharmacological agents directly induce this imbalance, notably antidepressants, steroids, and beta blockers. While the underlying neurochemical failure is uniform across the disorder, the diverse range of triggers and temporal profiles requires highly targeted clinical profiling. This clinical flowchart maps the diagnostic thresholds for the disorder. To officially diagnose clinical insomnia, the disruption must occur regularly despite the patient having adequate time and opportunity to rest. The condition is classified as acute insomnia when sleep disturbances occur at least 3 nights per week for less than 3 months. This profile is usually tied to temporary stress and typically resolves once that stress passes. Chronic insomnia is diagnosed when these disturbances exceed the 3-month mark at a frequency of 3 or more nights a week, leading to measurable daytime impairments. Patients on this chronic pathway face cognitive deficits, mood disturbances, and acute risks on the road, where struggling to stay alert compromises driver safety. Before confirming a diagnosis of primary insomnia, a clinician must evaluate the patient's history to rule out secondary physiological causes. These masquerading disruptors include restless leg syndrome, obstructive sleep apnea, hyperthyroidism, and phases of mania. An accurate diagnosis depends on isolating primary hyperarousal from this host of secondary biological disruptors. The first-line intervention for this disorder focuses on systematic sleep hygiene. By eliminating late-day caffeine and alcohol and avoiding daytime naps, patients actively manipulate their adenosine drive and circadian regulators to rebuild a proper sleep debt. When lifestyle modifications fail to suppress the state of hyperarousal, targeted pharmacological intervention becomes necessary. Clinicians deploy specific classes of medications, including benzodiazepines, non-benzodiazepine sedative hypnotics, sedating antidepressants, and melatonin agonists. These agents target the exact neurotransmitter pathways mentioned earlier, like GABA and melatonin, chemically forcing the sleep centers to overpower the arousal network. Treating insomnia requires recognizing a jammed neurological switch and using precise interventions to manually reset the brain's delicate balance.